your microphones on mute. That'll keep the background noise down so we're not distracted from a great presentation that we have this morning. We are pleased to have Dr. David Aronoff, the Director of the Division of Infectious Diseases at Vanderbilt University Medical Center right here in Nashville, joining us today. Dr. Aronoff has been highly involved in the diagnosis and clinical care of COVID-19, as well as serving in a pivotal role as a key communicator of public health measures during the pandemic through frequent media appearances, educational activities, and direct relationships with employers. We are very thankful that Learning Committee member Judy Gattina helped us find Dr. David Aronoff, who happens to be a friend of hers. I know you're all anxious to hear from the expert. We've got ample time for Q&A, and I encourage everybody to put your Q&A in the chat, and myself, Samara, and Marla will pool those questions and get those to Dr. David as we have time. So unless there are any questions, Samara's already started sharing her screen. Doctor, it's your floor.
Great. Can you hear me okay?
Yes, sir.
Excellent. Well, thank you very much for the kind introduction. I am really excited and honored to be able to present and have some Q&A with all of you at EO Nashville. Of course, this is a typical Friday of chaos. I came into my office here at Medical Center North at Vanderbilt Medical Center to find the internet down. So we're doing this a little bit jerry-rigged, and so I'm holding up my cell phone talking with you and having slides controlled by the great folks at EO Nashville, but we'll get through this as we are the pandemic. It looks like when I look at the screen, there's an email pop-up maybe, and I don't know if that is something everybody can see, but there we go, now it's disappeared. If we can go to the next slide, please. So this is what I'm gonna talk about. I'm gonna try to go through these slides pretty quickly because I really wanna get to Q&A. These slides will be readily available to you, and we're recording this as well, and I'm happy to share any knowledge with you at any time. But we're going to talk a little bit about where we are today, some of the clinical features of COVID, and a little bit about testing. I'll talk about how we're treating patients with COVID-19 and get into the real recent vaccine updates. Talk a little bit about transmission and protection, particularly around the holidays, and then we'll really get into some Q&A. So if we could have the next slide, please. And then the next one. So this is where we are today. This pandemic is really very active still. Globally, we've seen over 70 million people diagnosed with COVID-19. That's really an underestimate because many people with the disease have not gotten formally diagnosed with the infection. And unfortunately, there have been over 1.5 million lives lost globally from COVID-19. In the United States, we just crossed 16 million people diagnosed with COVID-19. And we're now logging basically 1 million new cases every 5 days or 6 days in our country. 16 million people is a lot of people, but that's basically 5% of our country's population. So even though we are grossly underestimating the burden of the disease based on testing, it's clear that a majority of people in our country still are susceptible to this infection, which is new to humans. And we're approaching 300,000 deaths across the country at basically a clip of 3,000 or more lives per day. That's more lives than were lost in Pearl Harbor, more lives than were lost in 9/11. And we're basically seeing that on a daily basis right now. In Tennessee, we've obviously been no stranger to COVID-19. It arrived in March, and we've now diagnosed over 420,000 people with the infection and seen over 5,200 lives lost. And we're recently having record numbers of people in the hospital. Just 2 days ago, we broke a record with 2,600 people in the hospital with COVID-19 across the state. And then where I am, and probably many of you are in Nashville, we've seen over 52,000 people diagnosed with COVID-19 and approaching 400 deaths, with basically 400 plus people in the hospital on any given day. If we can go to the next slide, please. So this is a heat map of disease activity from across the country as of yesterday evening. And the way that this map is laid out is that green areas have the lowest disease activity and red areas have the highest disease activity. And the disease activity is basically the number of new cases of COVID-19 that are diagnosed every day, normalized for the population. So per 100,000 people, all these little regions that are boxed out in the US are counties. This is county level information. And actually the leading state right now for disease activity is Alaska. Tennessee is right in the top 25. I think yesterday we were 23 in terms of disease activity. If we go to the next slide, please. So this is where we are as a nation over time. So the y-axis or vertical axis of this graph are the number of cases that are diagnosed. And on the long or x-axis or floor of this graph is time, basically dating from March until yesterday. And every one of these tiny orange bars that's going up and down are the number of cases in the United States diagnosed on a particular day. And you can see that there was a little bit of a mogul in April, a little bit bigger of a peak in late July. And now we're really heading up and up and up into this third wave of disease. And we can see that probably coming out of Thanksgiving, it took a turn a little bit more vertical, although we may still not yet have appreciated any bump from all the travel and gatherings around Thanksgiving. If we can go to the next slide, please. So I'm going to talk briefly about clinical features. These are things that I know are familiar to everybody, but I just want to emphasize that people who get infected generally will develop symptoms. Those symptoms on average pop up at about 5 days after infection, but they can arrive anywhere from 2 days after infection to as far out as 12 to 14 days. Usually after 10 to 12 days, about 95% of people have symptoms if they were going to have symptoms. But it is really important to note that 20 to 40% of people who get infected never develop symptoms. They are truly asymptomatic people. The other thing is that the rest of us who develop symptoms spend about 1 or 2 days before our symptoms begin, making lots of virus and shedding a lot of virus unbeknownst to us, completely asymptomatic. And that's called the pre-symptomatic phase of the infection. So between pre-symptomatic people and asymptomatic people, there's a lot of shedding and potential transmission by people who don't know that they're infected. But the symptoms we worry about are shortness of breath, cough, and fever. That might signify pneumonia, but we do see loss of smell, loss of taste, because the virus can damage some of the sensory nerves that are responsible for those senses. And we do see people whose primary symptoms are diarrhea or nausea and vomiting. It's a pretty strange infection in that way. Next slide. Some of the outcomes in Tennessee and around the world are death, which is horrible. And yes, we know that about 1% of people who are diagnosed with COVID-19 will die from it. But this graph illustrates something really important. So the blue bars are the total numbers of cases that we have diagnosed in the state of Tennessee, basically stratified by age group. And you can see that people in the 21 to 30 age group are responsible for the most diagnoses of these cases. And you can see across other ages. In fact, as you get older, above 70, those are the minority of cases that have been diagnosed. But the red line is the fatality rate. If you get diagnosed, what fraction of that population dies of the disease? And you can see that for people over 80, basically 15% of the people over 80 that are getting diagnosed with COVID-19 are not surviving the infection. So yes, mortality is low overall, but it is dramatically different based on a person's age. Next slide. We're also learning that people can get reinfected. There have been 26 cases around the world, which is a tiny fraction of total cases, where there's very, very solid evidence that people got infected, completely recovered, cleared the virus, and then got reinfected with a virus from somebody else. But there are about 1,600 to 1,700 cases where that's highly suspected, but just hasn't been proven with certainty. I think the main point here is that we think that immunity does wane over time. Nobody has survived COVID-19 for longer than a year, as far as we know, because the pandemic is so new. So we don't really know if people are protected after natural infection beyond a year, but it does appear, particularly with asymptomatic or mild infection, that our immunity wanes over time. Next slide, please. So let's get into some testing issues. And I'm just going to briefly say that right now there's essentially 3 ways that we test for infection. And 2 of those ways are how we test for active infection. The gold standard right now are called molecular tests. Sometimes you hear them called PCR or nucleic acid amplification tests. Basically, these are tests that are looking for the genetic signature or code of the virus, the little strand of RNA that's inside the shell of the virus. Those tests, those molecular tests that we do on nasal swabs or saliva are very, very sensitive. They can pick up trace amounts of the nucleic acid of the virus. They can still be falsely negative. Not everybody who's infected has a positive molecular test, but they are very, very good tests. The second type of test for active infection is called an antigen test. And the antigen tests are not detecting the genetic material of the virus or the RNA, but they're detecting the shell of the virus, which is made out of protein. Those tests, the rapid antigen tests, often take 5 minutes to do and are similar to a urine pregnancy test in sort of how they're performed. Those detect basically intact virus. And so being positive by an antigen test is important because that's suggestive that someone is shedding whole intact virus and is likely to be contagious, while molecular tests can detect RNA in somebody who's not actually producing intact infectious virus. This is an important point because we know that most people who recover from COVID-19 stop being contagious somewhere before 10 days after their symptoms begin, but they can still have a positive molecular test for weeks and weeks and weeks because small fragments of RNA from the virus can still be being generated in their body or being detected, while the antigen test tends to track better with contagiousness. I'm not going to talk a lot about antibody tests. Antibody tests are blood tests that are basically trying to ask the question, has this person previously been infected with the SARS-CoV-2 virus? We're not really using these antibody tests a lot at Vanderbilt for a couple reasons. One is there are false positive results, possibly cross-reaction of our antibodies to other coronaviruses that cause things like the common cold. In addition, we know that people who are asymptomatically infected or mildly infected may not get a robust enough immune response to get blood antibody levels that are high enough to measure. And in that sense, that becomes a false negative antibody test. And people with infection who recover lose their blood antibodies over time. And so if I had bona fide diagnosed COVID in April, by now my antibodies may no longer be detectable. And so we can't really use that as a litmus test to see if someone's had COVID-19. And not all antibody tests are testing for what we consider to be protective antibodies. And so we don't even know that we can use these commercial assays to tell somebody that they're at no risk for getting infected or reinfected. Next slide, please. So just to summarize a little bit about testing for active infection, the molecular tests, the nucleic acid amplification tests and PCR, are definitely more sensitive than the antigen tests, which detect the shell of the virus. And a positive molecular test is very helpful, but it's not clear if they're positive that they're contagious because they may be getting picked up really early in the course of their infection before they're contagious or well after the point of being contagious. So we have to take that with that sort of interpretation. A positive antigen test can really signify that somebody is shedding a lot of virus. It is possible to have a false positive antigen test, particularly in people who are at very low risk for being infected. But if somebody's symptomatic and has a positive antigen test, they're highly contagious. Or if somebody's a close contact to a case and has a positive antigen test, they're likely infected and shedding virus. So I think for either of these tests, a positive result is helpful with a capital H because that really suggests you should be isolating we need to be tracing your contacts. You're likely infected. A negative test is helpful with a lowercase h, but not super helpful because false negatives definitely can occur. People can be infected with the SARS-CoV-2 virus and have a negative molecular test or a negative antigen test. And that's important to know because that may influence their behavior. I'm going to go to the next slide, please, if we can, about treatment and vaccines. And we'll go to the next one. And just to say, there right now are 2 treatments that we use for hospitalized patients that have been shown in randomized controlled trials to be of benefit. One is the antiviral drug remdesivir, which was actually taken off the shelf of Gilead Pharmaceuticals by Mark Dennison, who is the director of pediatric infectious disease here at Vanderbilt. He's been studying coronaviruses for over 30 years, and he had the bright idea that that drug, which was initially developed to treat Ebola, might be useful to treat coronaviruses. And so several years ago, he was working with Gilead to get that drug to test. And lo and behold, it does have activity against SARS-CoV-2. It accelerates recovery time for people who are on oxygen in the hospital. Unfortunately, it has to be given IV, but we use it quite a lot. And relatively inexpensive generic anti-inflammatory medications like dexamethasone, which is a prednisone-like corticosteroid, have been shown to actually improve survival of patients who are in the hospital requiring oxygen with COVID-19. Next slide, please. More recently, for use in people outside of the hospital, are monoclonal antibodies. So monoclonal antibodies are basically antibodies which are generated in the lab that are just like our own human blood antibodies. They bind to the part of the virus that's responsible for the virus attaching to our own cells. And by these monoclonal antibodies binding to that spiky part of the virus that's important for the virus attaching to our cells, it blocks that attachment and reduces the likelihood that we're going to have a severe infection. And in fact, the Eli Lilly monoclonal antibody and the cocktail from Regeneron have been shown to reduce the risk of hospitalization and emergency department visits, but have been shown most helpful in people who already have a very high risk of needing to be in the hospital. And so those are people who are over 65 or have medical conditions like high blood pressure or diabetes, or are immunocompromised, like undergoing chemotherapy or have an organ transplant. So we're really targeting people at high risk of being hospitalized with COVID-19 to keep people out of the hospital. Next slide, please. These are headlines from yesterday. Yesterday was a busy day for all of us who are caring for patients with COVID-19 as we anticipate having vaccine available. For us, vaccine is really the light at the end of the tunnel. It's the way out from underneath this pandemic. And it's a reminder to all of us that we're still very much in the tunnel, even though we're starting to see the light at the end. And yesterday, the FDA endorsed the Pfizer mRNA vaccine and granted it emergency use authorization. And we're going to hear more from the Advisory Committee on Immunization Practices probably late today in terms of exactly who the vaccine is being recommended for. Next slide, please. So I just wanted to briefly tell you how these mRNA vaccines work. So corona, in the name coronavirus, means crown. And if you look at these viruses under a high magnification electron microscope, you can see little spikes on the outside that look like a crown. And that's how it got the name coronavirus. And it turns out that these spikes are like the Velcro on the virus that's responsible for the virus binding and attaching to our own cells and making us sick. And so antibodies that are raised in our body against these little spiky proteins can block that from happening. Now, the virus itself has this shell, this spiky shell, and inside of it is this single strand of RNA, which is a nucleic acid. It's the genetic material that once the virus gets into our own cells, it instructs our own cells to start making more of this virus, more of the RNA and more of the shell. And then our cells die doing that and make a lot more virus that then spreads throughout our body. And so if we can block that process from happening, that's what we do. And so what the scientists who developed this vaccine did was just take the piece of RNA from the virus that doesn't give instructions for making the entire virus, but just gives the instructions to making that spiky protein on the outside. And so we can inject that little bit of RNA fragment, which is not actually from the virus, it's synthesized in a lab, it's made artificially in the lab, but that little message gets injected into our muscle. It gets taken up by our own muscle cells who think it's a piece of RNA like any other. Our own cells make RNA, and it reads that RNA and makes spike proteins, these little spiky proteins, and it spits those proteins out into our blood. And then our immune system wakes up and says, wait a minute, that doesn't belong to us, that's foreign, and makes antibodies. And those antibodies are now armed and ready for us in case we get an actual infection with this little spiky critter. These antibodies are there to block that. If we can go to the next slide, please. So this next slide basically tells you what I just told you, which is there's this little purple particle, which is called a nanoparticle, which is a fatty lipid little droplet that inside of it has this synthetic piece of the viral RNA that gives the message to a cell to make this spiky protein. Our own muscle cells, which right here are shown as this huge blue cell, take up this RNA and they make the spiky proteins that then get secreted or displayed on the outside of the muscle cell. And that's what provokes our own body to make antibodies. In the meantime, while our body's making antibodies, the original RNA that was injected gets destroyed. RNA is very unstable and it gets degraded and destroyed. And even these spiky proteins will eventually go away, which is one reason why we boost people with a second shot several weeks later to boost that immune response. Next slide, please. So let's talk a little bit about transmission and protection from infection, just to make the point that we think that about half of new infections are transmitted by people who are either pre-symptomatic or asymptomatic. And that's been the nefarious part of this pandemic, is that people are spreading the virus and they have no idea that they're doing it, which is why each of us has to act as if we are infected. And we have to limit our meetings with other people, and we have to wear face masks when we're around other people because we just don't know who's infected and who's not. Next slide, please. I love this cartoon, which was featured recently in the New York Times and was drawn by a virologist in Australia, Ian McKay. And it's basically called the Swiss cheese model of preventing infection. And I think it's really, really a good way to think about this, where on the left side of the slide are viruses, and on the right side of the slide is you or me. And how do we keep the virus away from us? We do that by using a bunch of different techniques. Each of one is not perfect. Each one has a hole in it, and that's the Swiss cheese analogy. But the more of these we line up, the more likely it is that we will impede the virus from going from my breath to your breath, for example. And that includes things that are personal responsibilities, like creating physical distance, wearing our masks, engaging in hand hygiene, not touching our face, etc. And it also involves shared responsibility of having the ability to do testing and tracing and taking care of things like improving ventilation and air filtration, and doing lots of messaging and investing in research and getting vaccines available, et cetera, et cetera. If we go to the next slide. I'm going to close a little bit with quarantine and holiday things. If we can go to the next slide and just say that the CDC has revised guidelines around quarantine. So the first thing to note is that the reason quarantine is safest for 14 days is that it can take up to 14 days for people to develop symptoms. Most people will have had symptoms by days 10 to 12 after infection. And on average, actually, it's about 5 days after infection. But there are cases of people getting symptoms on day 13 or 14, and that's still the safest way to quarantine. However, we know, and part of this is driven by the efforts to get people back to work and try to keep people from having to quarantine for 14 days, that we know that 10 days is really pretty good. And if somebody can go 10 days without symptoms, their risk of infecting other people is actually very, very low. particularly if for the next 4 days, they're very careful to be wearing their masks, limiting their exposure to other people, and essentially isolating from others to the extent possible for those next 4 days, even if they're back at the workplace. The other way that is acceptable now to get out of quarantine is to go back to work or come out of quarantine on day 8. If by day 7, you don't have any symptoms, and if you've had a negative test, either a molecular test or an antigen test, within 48 hours of that day of release. So if you're coming back to work on day 8, that means you were asymptomatic on day 7, and somewhere at day 5 or 6 or 7, you had a negative test. There's still some risk associated with doing this. And that's why the CDC has said that if you work in an environment or run a business where you cannot afford to have somebody who is infected in your business or can't afford to have an outbreak, you should stick with the 14-day quarantine or the 10-day quarantine. Next slide, please. This is just a graphic that I took from the state of Tennessee, and I can send these out to EO Nashville. But just to say that if somebody's a case, they're basically contagious for 10 days from the point of symptoms beginning. If they never had symptoms, it's hard to know exactly how long they're contagious. So we consider people contagious for 10 days beyond their positive test. But for symptomatic people, they're considered contagious for 10 days from the beginning of symptoms, assuming that their symptoms are getting better by day 10. They don't all have to be gone, but they have to be getting much better, and they haven't had fever for at least 24 hours. That's what isolation of a case is all about. Next slide. Quarantine of household contacts who cannot separate from the case is important. So quarantine, as I mentioned, is 14 days or 10 days without symptoms, and then sort of being vigilant for an additional 4 days, or the testing, as I said. But that period of time does not begin until the case that you keep getting exposed to is no longer contagious. And so that's where this initially 24 days of being on quarantine occurred, which now might be shortened to 17 days, for example, using this cartoon example. Next slide. On the other hand, if you're not a household contact, you got exposed at work, but you don't live with the case, or you do live with a case, but you absolutely can quarantine away from the infected person, then you're basically on the schedule that I already laid out of 14 days or 10 days or 7 days with a test. And that's, I think, an important distinction. Next slide. So let's talk about the gift-wrapped virus here and talk about holidays. And I'm not going to go over this slide in detail. It's available to you for sure through my slides and the CDC. But just to say that this virus is simple. It's just RNA with a protein shell. It has no brain. It has no ability to think about why people get together. But it can absolutely take advantage of the fact that people get together. The virus goes from person to person primarily through our breath, and that's accelerated when we're close to each other, particularly in poorly ventilated areas and particularly without mask protection. So whether that's a Thanksgiving holiday, a wedding, a funeral, a religious holiday, a church service, it doesn't really matter. The virus can go from person to person. So as we plan for holidays, we need to be thinking about that Swiss cheese model of disease prevention. Next slide. And that includes the ways that we travel. So it's important to check travel restrictions before you travel and think about, are we going to be okay if we get stranded somewhere? If we get sick or quarantined in a different location, is that okay? Do we know what our health insurance will cover? Do we know who to call if we're in a different city and get sick? Always make sure you get your flu shot this year. We're starting to see flu now. I've cared for a patient this week who had both influenza and COVID. And so we're starting to see that. Always wear a mask in public settings. Try to distance from others. Obviously, that's hard to do on an airplane, except for wearing masks. Airplanes do benefit from having very, very good air filtration, but they're not risk-free environments. And we don't know how much virus is transmitted from person to person through our hands, but we really want to minimize that, not only for COVID, but other infectious diseases. So keep your hands clean. Next slide. And I think that's it. I won't go over this conclusion slide. We can go to the next slide. And just what I want to say to all of you at EO Nashville is thank you. I appreciate the fact that you're concerned and caring. You're doing the part that's really important to help our community. This is not a pandemic that we're going to get through based on infectious disease experts' behavior like me, but it's really something that we're all in together. I'm very appreciative to be here. I apologize for the audio video issues that required me doing this through my cell phone with help advancing slides, but such is life in 2020, and I'm happy to take questions.
Thank you very much, Doctor. That was very informative. And I think you've answered a lot of our questions, but I will definitely go through them all just to make sure that everybody's got an opportunity to hear a bit more about some of these topics. And I'll start with this one right here. We've got a question from Judy talking about, she's had she had a positive test, she had symptoms, she's recovered now, and she's wondering if her plasma might be of benefit to someone else or some medical research possibly.
Thank you very much for that question. And hi, Judy. It's good to get a question from you. That's a really important one. Yes, is the answer. There are actually right now randomized controlled trials going on to see if convalescent plasma that's taken from people who have recovered from COVID, save lives or reduces disease duration. Vanderbilt is actually leading a $34 million multi-center trial right now across the country. That's the one that Dolly Parton launched with her investment at Vanderbilt Medical Center. And we absolutely need volunteers. I can share that information through EO Nashville. It's on our website at Vanderbilt. And if you Google probably donate convalescent plasma Vanderbilt Medical Center, you'll find it, but I'll make sure that you have that. I appreciate you bringing that up. And I want to say, if we don't have time to get to all questions, Mose or anybody can email me questions. And in the next 24 to 48 hours, I'll pound out some answers and get them back to you.
Fantastic. So this one comes from Austin. Everybody, of course, I love going out to restaurants. Where does the restaurant industry fall possibly in the vaccine distribution?
Yeah, really, really good question. So I'm not totally sure exactly which phase they're going to be in, but most would consider those essential workers, people who are in the service industry and have to be at work every day and really are in front and are often staffed by people who are at high risk for doing poorly with COVID-19. And so my guess is that they will be pretty soon in line as we're phasing through. Right now, what we've been concentrating on mostly, we're getting some Pfizer vaccine next week, which for phase 1A from the federal government and the state is really the frontline healthcare workers and first responders who are working with people who are likely to have COVID or do have COVID. So we're desperately training people, doing frequently asked questions, getting all of our ducks in a row. Next up is going to be essential workers and then the general public. And we're certainly hoping to have vaccine available for the general public. I hope by spring, although I'm not totally sure because I don't know what the supply chain looks like.
Yeah, Doctor, when we were talking with you earlier, as we set this meeting up for everybody, we talked a bit more about the vaccine. And I don't remember the term you used, but you said the vaccine is a particular type and it can make people feel ill in the process of creating the protection that it does. And you mentioned that might you might have to phase. So as an employer, if I want to have people vaccinated, I might have to spread that out so that they don't all feel like crap at the same time.
Thank you for bringing that up. That's an awesome question. I think this is going to be a really important point for getting people to take up the vaccine. So the vaccine is these mRNA vaccines, which are 2-dose vaccines, and it's been shown that giving 2 doses really does boost our immune response. We get the highest levels of antibody. In fact, the immune response to the vaccine is stronger than the natural infection, particularly with this boosted second dose of the vaccine. These are really potent vaccines, but they're highly reactogenic, which means that they really make your immune system wake up. So the first shot is generally the easiest to tolerate. The second shot, your immune system's already armed against this little spike protein. So when it sees it again, you get a very robust immune response, and that can translate into a very sore arm. It can translate into having fevers. It can translate into being really wiped out and feeling like you got hit by a bus. It's important to note that in the study subjects, which now there have been over 30,000 people who have gotten the vaccine, that they categorize those as mild to moderate systemic effects or arm effects. What that means is that your immune system is working. You're getting a good response. The vaccine cannot give you COVID. It's not a live virus vaccine. It doesn't make you contagious, but it can be confusing and it can make you feel horrible. And so, and it doesn't affect everybody that way. We've known people who've gotten the vaccine who probably got the vaccine through our randomized controlled trials, who said, I felt a little bit under the weather, but it wasn't horrible. But I think we do need to prepare for that, that if you're lining people up for a vaccine and you have an essential group of your employees, you might not want to time them exactly on the same day, because what if they all feel terrible the second day after their second dose? And if they're symptomatic with fever, you don't want them coming to work anyways. So I think that's where that issue could be important. And we're going to have to see how each of us helps to message that, because the last thing I want to see is people not get the vaccine because they've heard people don't feel well after they get it. What I want to be able to say to people, which is true, is that the reason you don't feel well is that you're mounting a huge immune response. It's a safe immune response, but it's an important way that we know that we're armed and dangerous. We're ready against this virus. Bring it to us. We'll take it. We'll handle it.
Fantastic. Thank you for going over that. Here's a question from Dusty Ramey, and it's two things I don't know anything about. She's asking, there's a Pierre Corey saying that ivermectin might have amazing results against the virus. I don't know if I pronounced that at all right.
Yeah, I've got it. So thank you very much for bringing up that point. I think it was Dusty that asked that.
Yes.
So that's probably a question about the medication ivermectin. Ivermectin is a medicine that's been used in infectious disease for a really long time. It's effective against certain parasitic infections and also body lice and head lice. And it's a pretty safe medication. And there have been ideas that it might be useful in preventing COVID-19 or reducing symptoms. So far, it has not been recommended by people like the Infectious Disease Society of America or the NIH or the World Health Organization, because the evidence supporting its use is pretty weak at this point. Remember this is a really important point for people to understand, that even if we just look at the data in Tennessee, which are basically the same as global data, that for every 100 people who get infected or diagnosed with SARS-CoV-2 infection, about 3 to 4 of them are going to end up in the hospital, and about 1 of them is going to die of the infection. And what that means is that about 96 out of 100 people who get infected are going to recover or be asymptomatic or have a very mild illness. And so if you brought me 100 patients right now who just got diagnosed with COVID-19, I could almost do anything to them, like wave a magic wand in front of them and say, you're all going to get better. And I would largely be right. I mean, sure, I could say there's going to be a few of you who might be unlucky and end up getting in the hospital or dying, but the vast majority of you are now going to get better because of my magic wand treatment. And that's the kind of thing we're up against when people have what sound like reasonably good ideas for vitamins or nutritional supplements or drugs that they think will work, because they have 10 patients who come into their office, they give them this cocktail, and sure enough, those 10 patients do fine. The way that we actually can ask, does ivermectin or any other therapy actually work, is to basically randomize people who are diagnosed with the infection to get a placebo or to get the drug of interest in a blinded way where they don't know what they're getting and I don't know what I'm giving them. I don't know if I'm giving them a placebo or the active drug, and then seeing how those people do. So for example, if 100 people in a trial got a drug that we think works and another 100 people got placebo, and then at the end of the day, in each group, the exact same number of people ended up in the hospital, the exact same number of people died, we would know, you know what, this just doesn't work. Or if it does work, it's a very weak drug, and we'd need way more people to see a signal. So that's a long-winded answer to an excellent question. Right now, ivermectin falls into that area where we just don't have good evidence. that we can recommend it. So we're not using it at Vanderbilt, but like a lot of things, people have ideas that they think will be helpful, and that's still one of those.
Fantastic. Thank you. Oh gosh, we're getting a ton of great questions in here, guys. Thank you so much. I guess I'm gonna grab a question from Mike Rustici and Aaron. What is the end game? I mean, what percentage of the population needs to be vaccinated? How many people need to get infected before this is just the common cold again? Or once again, I shouldn't say the common cold, but it begins to fade into the lexicon of being a cold that we can manage and prevent and keep the most at risk safe.
Yeah, thanks, Mike and Aaron, for that question. There's been a lot of modeling going into this to try to understand just how many people would need to be immune to this virus to stop it in its tracks and prevent the pandemic from continuing to spread. And it's probably in the 60 to 70% of people need to be immune, with the rest of the people still vulnerable. So right now we know about 5% of the population has definitely been infected. You know, even if that's let's say 10 times an underestimate, then that suggests maybe we're close if 50% of the population's already been infected, but we really don't know. The other thing is that natural infection, particularly if it's mild or asymptomatic, may not provide long-term protection against reinfection. So if you had a mild infection in May, you may not be protected fully and be capable of getting reinfected. So what I would like to see is evidence either by diagnosis, like now 5% of the population's been diagnosed, but a combination of people who have definitely been diagnosed and immunized that's getting above 50% to 60%. You know, the reality is that we're going to learn about how many people need to be immunized to slow the pandemic down, because as we start immunizing people, we're hopefully going to see the number of new cases and the number of hospitalizations and the number of deaths start to go down. And that's what I want to see. So I don't really care if it's 40% or 60% or 70%. I want us to start immunizing people and watch very closely to see that hospitalizations, deaths, and new cases start actually fizzling out. So how's that for sort of a not specific answer?
Well, I think that, there's a lot of question marks here, and that's part of what we're all struggling with. And, we're all looking for the silver bullet, I think, and it just doesn't exist is kind of what you're saying. I mean, it's going to be a process, and we're going to have to walk through it. Which once again, so this is, and I know you've covered this, but coming at it from a different maybe a little bit different angle. And I think I mentioned this when I was talking with you as well. Could you cover both the question as an employer? An employee comes to me and says, my wife was with somebody that got COVID. Should I go quarantine? And, or, if you've been exposed to somebody, and I guess maybe a bit more about what exposure might be. If I bump into somebody in the grocery store for 2 minutes and they call me tomorrow and say, hey, I woke up today and I don't feel well, do I need to be concerned?
Yeah, those are really sort of two embedded questions. First of all, if somebody's a close contact of a case, and I'll get into that, they go on quarantine. If you're a contact of that person, you don't go on quarantine. You should still do all the things that we've talked about, masks and social distancing, and hopefully, to the extent possible, stay away from the person on quarantine. But as a contact of a contact, your behavior shouldn't be any different than it is right now, which hopefully is good behavior. But that's one reason why it is super important for those contacts, whether they're doing a 7-day, a 10-day, or a 14-day quarantine, they have to really get tested to find out if they're no longer a contact, but they're an actual case. So if you're doing a 14-day or a 10-day quarantine where you're staying at home and you're monitoring for symptoms, you should still get tested somewhere between day 5 and day 10, somewhere in that window, to see if you're actually a case and just don't know it yet. It's important to understand that testing isn't perfect. It can be a false negative, but a positive test is really, really helpful. So especially if you're living with someone who is a contact and you can't separate from them, make sure that that contact gets tested, because if they turn into a case, you're now a contact. Let's talk about what it means to be a contact. Basically, the rule of thumb is that if you're within 6 feet of somebody, which is based on how far our respiratory water droplets generally fall out of the air when we're speaking or breathing, and it's in those respiratory water droplets that the virus tends to travel, that's where that 6 feet sort of comes from. Now, it's important to recognize that that's not an absolute rule of physical law, that virus goes out 6 feet and then drops out of the sky. In fact, we can still disperse smaller droplets that can travel farther. If we're in a warm, dry environment, those little water droplets can evaporate quickly and become tiny and travel farther. But as a general rule, it's a relatively safe buffer zone of 6 feet. So if we're within 6 feet of a case for at least 15 minutes, cumulative over a 24-hour period, that's what we're considering to be a close contact. That is a general public health definition, but there's a lot of nuance there. So for example, let's say that you and I work together, I'm infected and I don't know it. I take off my mask to get a drink of water. You walk by me and I accidentally cough right into your face. Boom. And then it turns out the next day I get diagnosed with COVID-19. You're a contact. You got coughed on directly by me. Our interaction was brief, but that's a high risk transmission event. Similarly, if you're traveling around in a car without masks for somebody and you're just going to the grocery store, or picking somebody up and it's a 5-minute ride, but it turns out that the next day that person's got fever and was symptomatic and diagnosed, you know what, I'd probably consider that 5-minute car ride next to each other as a close contact. So there's not a legal rule about like 6 feet, 15 minutes, but I really think that that's a good way that we can start and then think about things that may mitigate that as well.
So I guess this leads me to bring up a great question. I'm going to do my best to get to the rest of the questions that are coming in on the chat. So the car ride example is great. My wife and I ride in the car. Neither one of us are wearing masks. So let's just say tomorrow we say, look, if we're riding in the car together, we're going to wear a mask. So actually, that's probably not a good example. A coworker of mine, we're wearing masks because that's our employer responsibility. We're wearing masks in the car together. So we're both wearing masks. We both ride. The next day, he wakes up and says, I don't feel well. Am I required to quarantine even though we were both wearing masks?
Yeah, so the CDC guidance about 6 feet, 15 minutes is meant to be interpreted independent of any other things that people were doing to mitigate infection in terms of masking behavior. So, I mean, obviously physical barriers count. So if you're in a different room, even if, like, let's say you and I are separated by 3 feet, but there's a brick wall in between us, I mean, that counts as mitigation. But if we're in the same room for 15 minutes within 6 feet of each other and you're a case and I'm a contact, the CDC says it doesn't really matter if we're wearing masks or not. Now, obviously, we know that wearing masks reduces the risk of transmission. So the likelihood is less that you would actually test positive. But right now, for the sake of public health, given how rapidly this infection is spreading, we're being a little more conservative and saying we're not going to count the nuance of wearing a mask. You're just on quarantine. If we had better access to more rapid tests, we probably could do that a little bit differently, but we haven't been able to so far. And so right now we're not considering masks as a mitigation event. But if you gave me that example of, like, I took a 5-minute car ride with somebody who was asymptomatic, turned out to be a case the next day and was wearing a mask, again, I would think, just how important is it for you to be at work? Can you work from home? Is there a replacement for you? I would try to err on the side of quarantining you. I might try to make it the shorter 7 days with a test to get you out of quarantine. And if you were absolutely essential to being at work and couldn't miss, and it was that sort of nebulous 5-minute with mask interaction, I might say, look, you can be at work, but wear a surgical mask, which is a better form of protection than a cloth mask. Try to be outside of direct interactions with people. We'll move you to a part of the business where you don't have to be in the face of others for the next week or something. And I would try to do things in the built environment just to be careful, unless a public health official called me and said, no, that person's absolutely out.
Okay. Thank you very much. So here's an interesting question. Obviously, there's a ton of information on the socials, the internet. If you could debunk, or I guess debunk's a great word, a single piece of misinformation surrounding the virus, the vaccine, what would you debunk for us today?
Well, that's such a really, really good question. So there's a couple of them. One is that there's this myth that the reason that we're saying there's all this COVID activity is just because we keep testing for it and finding it. And first of all, we're still not testing enough people. But the way that we know it's that this is not simply an artifact of doing a lot of testing is twofold. One is the number of people in our hospitals with COVID is climbing. If this was just a matter of finding asymptomatic people with an infection, then it wouldn't burden our hospital system. And the same is true for the number of deaths. So that's really important. The other is that if we were just simply finding more cases because we were testing more and more and more and more people, we'd actually expect that the percentage of tests that we do that are coming back positive would sort of get lower and lower the more that we test, because we just make the assumption there's a certain number of COVID cases that are not growing, and we just keep testing and testing and testing. Yes, we'll find more cases, but as a percentage of the tests we're doing, it's going to be a low number, like 5% or 2%, and it's going to go down the more we test. We're seeing the opposite right now. We're seeing positivity rates that are going up and up and up. So, a few months ago, 5% of tests in Tennessee were positive. Now we're at about 15 to 20% of the tests. I mean, right now at Vanderbilt, when we test symptomatic people, about 1 in 3 are coming back positive. That is crazy more positive than it was like back in early September, or let's say May, where it was like 7% of tests were coming back positive from symptomatic people. We would test people who thought they had COVID, and maybe 7 out of 100 or 10 out of 100 would come back positive. Now it's like 25 to 30 are coming back positive. So that's one big myth that I think we just need to dispel. Our hospitals aren't being filled by people who just are in the ICU because their test was positive. The second is, ideas that this vaccination thing is a nefarious plot, or that people are putting microchips into people, or that it, is somehow anything other than giving people a piece of synthetic RNA to help them make these spike proteins to become immune to something that's killing people. This sort of anti-vaccine conspiracy theory kind of thing that I think we're all up against in public health, which is terrible. Yesterday, we'll see what the number is today, I haven't seen yet, but yesterday I rounded on 36 people in our intensive care unit who are struggling to live with COVID-19. And I can't sort of do that and think in good conscience of not finding every way possible to protect people from this. We want people to see 2021. And so anyways, those are probably the two biggest myths that I'm up against.
So let me throw one out that just came to mind while we were talking about this. On the internet, somebody showed me a video, and you talked about the virus, and I guess this shedding. You mentioned the word shedding a couple of times during the presentation, that I could have no symptoms and be shedding virus through my water droplets in my just normal respiration, correct?
That's absolutely right.
There was a gentleman that did a video where he was using a vape product and testing several masks. And so he would breathe in the vape and then exhale, and the cloud of smoke, the cloud of vape would go out the sides, all kinds of still leaving the person and not really being captured by the mask. What are your thoughts on that debunking?
Yeah, I mean, that's important. In fact, there was a study just published yesterday, I think in the Annals of Internal Medicine, basically getting at that exact issue. So we know by now from a lot of different types of evidence that wearing even cloth face coverings reduce the likelihood of transmission. They reduce disease activity in communities. They really, really help. They are not perfect. In terms of Swiss cheese, they've got some big holes in them. And in fact, the fit of a cloth mask matters in how good it is at filtering out these droplets. And so there are ways to get masks that are thick enough to be very good filters. Remember that the thicker a mask gets, the better filtering it does, but there's a trade-off in terms of breathability, right? We tell people to use 2-ply or 3-ply masks. The reason we tell people not to use 10-ply masks is that you can't really breathe through them, and they would be really heavy probably and tear your ears off. But we know that single-ply thin tissue, kind of like a single handkerchief, helps a little, but probably not very much. But we also know that when there's big gaps on the side of your mask, you are getting respiratory droplets out the side. So you want masks that fit better, and there are ways to do that. But that is an important point. Now, remember, we're trying to do masking in the context of a whole bunch of other Swiss cheese things that we went over, each of which is imperfect. We have to not let perfect be the enemy of good. If somebody says, well, masks still let air out the side, so that's why I think they're stupid, my response to that is that that's not a really appropriate way. People die in car crashes every day, even wearing their seatbelts, but I think we all know beyond a reasonable doubt that seatbelts help save lives. It's the same issue when it comes to masks.
Okay. Thank you, doctor. So we've got a little bit of time left. Looking through the questions. I mean, I guess what I'm seeing a lot of in the chat right now is with the vaccine coming out, and I think you've sort of addressed this, that we'll know more as people become vaccinated. Is this a vaccine that, like the flu vaccine, if I'm at high risk, I go to get the flu vaccine at the Walgreens? Is it going to be that sort of thing where every year you're going to go get a reboost on this?
Yeah, we don't know the answer to that. It sort of looks like the immune response to these vaccines is even stronger and better than natural infection, in part because we know that the type of antibodies that people's bodies are raising to this vaccine really do neutralize the virus. They really do prevent binding, and we get a lot of a good, strong immune response. But honestly, we really don't know how long that is protective. Again, not only have we been living with this pandemic for just about a year, but these vaccines have only been sort of trialed for 6 months or so. And so we don't have enough data to know, are we going to have to get another booster shot? Are we going to have to get a different type of vaccine? Is there going to be a nasal spray booster we could get at some point? I mean, these are all really, really, really good questions. I think right now our focus is to get out from underneath this pandemic, and what a luxury it would be to say, well, the pandemic's over. Okay, maybe we do need to get a booster in 2 years or something. That's a reasonable trade-off. But I don't know. And I'm actually really hopeful that if we do have to get a booster of some kind, that it'll be easy, single shot or a single nasal spray. Remember that this coronavirus is not like the flu. The flu actually, like, the strain changes every year. And so that's why we have to get different flu shots every year. This coronavirus isn't going to be a wholesale changing virus over the next year. We may get a different coronavirus into our human population in the future, which could cause a different pandemic. But this is not exactly like the flu. So I don't think we're going to see that it's a wholly different virus. I think hopefully our immune protection lasts a bit.
Thank you very much, doctor. This has been fantastic. It is 9 o'clock. I suppose we are supposed to wrap it up, start on time, finish on time. I know that there's probably some questions that we did not get to, or people would like some additional information. I guess, Samara, correct me if I'm wrong, Marla, correct me if I'm wrong. Email those to myself, Samara and Marla, and we will get them to David. I think, David, you offered to respond to questions as you had time if we couldn't get to them today, yes?
Yeah, and that's, I guess, the benefit of being Friday is I'll take the weekend to answer questions and get them to you by Monday. But again, I just want to tell you two things. One is, this is a huge honor for me to have you as an audience. I really, really appreciate it. And number two, just thank you for all that you're doing. I appreciate it.
Well, thank you very much, doctor. I appreciate it. I appreciate everybody's time and attention. I appreciate all the questions. Lots of thanks to you coming in through the chat. And once again, everybody, just Marla put her email up there in the chat if you want to email in some additional questions. And on that, I will bid everybody a safe and healthy weekend. And we'll see everybody again real soon.
Be well.
Thank you, doctor.